Welcome to the Mayo Clinic Ophthalmology Podcast, brought to you by Mayo Clinic. I'm your host, Dr. Andrea Tooley.
And I'm Dr. Eric Bothan. We're here to bring you the latest and greatest in ophthalmology, medicine, and more. Today on the podcast, we have a special guest, Dr. Orefe Adesina from Houston, Texas. He is not only a podcaster in his own right, which we'll hear about, but a neuro-ophthalmologist, an orbital surgeon, a strabismologist, and has a forte and expertise in diversity, inclusion, and as I mentioned before, podcasting. So we're excited to hear from his insights and perspective in practicing ophthalmology in these fields.
Dr. Orefe Adesina is a neuro-ophthalmologist and medical director of the Cizik Eye Institute at the McGovern Medical School at UT Houston in Texas. Dr. Adesina not only specializes in neuro-ophthalmology, but is an orbital surgeon, strabismologist, a global leader in neuro-ophthalmology, staunch advocate for DEI within ophthalmology, and mentor to trainees worldwide. Dr. Adesina also hosts 2 podcasts of his own, Out of the Blind Spot, focusing on neuro-ophthalmology, and Sight for Sore Eyes, discussing issues of diversity, equity, and inclusion in ophthalmology. Welcome, Dr. Adesina.
Thank you very much for having me. It's really a pleasure and an honor to be here. I love your podcast. I love the way that you do it. And as a podcaster myself, I really appreciate how well you ask questions and sort of do a good job with the interviews. So thanks for having me here.
Oh, well, it's so great to connect. We're so happy to have you here. You know, I remember we talked at AUPO earlier this year. We were talking about podcasting because you're a podcaster. I was kind of new to podcasting, and I'm so glad we could finally get you on. It's awesome. And then you and I have connected too through the Rab Venable program and your work with Rab Venable, which is just amazing. You've really done outstanding work. So I'm excited to talk about all the things. We have so much in common with strabismus, orbital surgery, residency, education. This is going to be great. I can't wait.
Looking forward to it. I'm happy to be here to have this conversation, definitely.
Yeah.
Andrea brought up your name to me in podcasting, and she just was bubbling with excitement about the opportunity to have you with us. And I've just enjoyed getting to know you recently, but share with our listening audience your journey into medicine and ophthalmology and neuro-ophthalmology. Just share kind of what your trajectory has been to set the platform for this special discussion we planned today.
Yeah, happy to. So I was born in a town called Elisha, Nigeria, to 2 physicians who were in the residencies at the time that I was born. You know, legend has it that I was delivered by my dad. While I was there, I can't independently confirm that, but that's what I was told. We moved to the States when I was around 4 years old for my parents to do postgraduate medical education here in the States. My dad did a pathology fellowship, neuropathology fellowship at University of Vermont. And then my mom ended up doing a pediatric residency, internship in Cook County in Chicago, and then Albany Med for residency. My dad then did a PhD in McGill University and postdoc work at the Fox Chase Cancer Center in Philadelphia. So we moved around a lot when I was a kid. Between the ages of 4 and 8, I lived in Vermont and Montreal, Philadelphia, and then West Virginia when my mom got her first job out of residency. We finally moved to Oklahoma, Norman, Oklahoma, when I was 12, when my dad got his first job after all of this training, faculty at OU Health Science Center in neuropathology. And I spent 18 years of my life between the ages of 12 and 30, went to medical school, high school, undergraduate at OU, and then medical school at OU, and then residency at the DMG Institute in Oklahoma City. I wanted to be a doctor as long as I could remember. Both my parents were physicians. I saw how much they loved what they did, how much people respected them. And like most kids, I kind of wanted to be just like my parents. And that never changed over time. All through my experiences still confirmed that I wanted to be a physician. So I went to medical school at OU. When I got to medical school, I didn't really know what I wanted to do. I thought I wanted to do something in the neurosciences. That's where my interest lay, maybe because of my dad's background. But then during my 3rd year, I spent time on surgery rotations, and I realized that I really liked being in the OR and doing procedures. Not necessarily as a general surgeon, but I wanted to do a surgical subspecialty. And then also during my 3rd year, I ended up doing a neurosurgery rotation. And initially I thought, man, this is it. They gave me the bird drill, I did a burr hole, and we were taking out tumors, and I thought it was fantastic. And then I took call with them, and then I realized that maybe I'm not quite about this life or lifestyle. But it was during that rotation that I went to a neuro-ophthalmology conference at Dean McGee, and it was run by Dr. Bradley Ferris, who was an ophthalmologist there at the time. And when I saw the cases and the pathology and the imaging, I was like, this is the coolest thing I think I've ever seen. And then when I realized that he did surgery, adult strabismus, optic nerve fenestrations, and I wanted to be a surgeon, and I was pretty much hooked. I rotated at Dean McGee. I figured out that I wanted to be an ophthalmologist. And by the time I graduated from medical school, I had pretty much decided that I wanted to be a neuro-ophthalmologist who did adult strabismus, orbital surgery, and functional eyelid surgery. And because ophthalmology is just a great, diverse, and versatile field, I was able to sort of blaze my own path to make that happen. And that's why I was able to do the job that I'm doing now, incorporate all these elements into my practice. I did my residency at Dean McGee, and I did my fellowship at University of Utah Marine Eye Center. And I've been here at UT Houston since I finished my fellowship in December of 2013.
Unbelievable. What a great story. I love that whole path. And, it's pretty unique that you knew not only about neuro-ophthalmology, but all the adjuncts you wanted to have in your career as a medical student going into residency. I think especially with neuro-ophthalmology, it's one of those fields that we have such little exposure to, especially in medical school. And you've done a ton of work in this space about the pipeline to neuro-ophthalmology and helping recruit more people into neuro. I'd love to hear about your efforts getting more people into neuro-ophthalmology, teaching more people. How do we kind of spread the word about neuro-op? You got to witness it firsthand as a medical student, convincing more people to choose neuro-op. Why is there a physician shortage in neuro-op? What do we do about it? And some of your work with the young neuro-ophthalmologists, Yono, Nanos, like all those kinds of things. To kind of tell us everything about your work there.
Yeah, I'd love to. I learned about neuro-ophthalmology in medical school around my third year, and I was in a different situation than most medical students because at my institution, our neuro-ophthalmologist was surgical. In fact, I didn't even know there were neurologists that did neuro-ophthalmology until I graduated from medical school, almost residency, went to do residency. So exposure is one of the big issues that we have causing our pipeline shortage. People don't really know what they don't know. If you don't know what you don't know, you can't be what you can't see to a degree. And that goes on the ophthalmology side and the neurology side. There's other issues that keep residents from doing neuro-ophthalmology, and I'll speak more on the ophthalmology side. That's more of my experience. I think it's a cognitively difficult specialty. There's the talk of reimbursement, patient volumes, the lack of surgery that is promoted to residents as well. It's heavily academic. You can't do private practice. And there's sometimes low exposure to mentors and mentoring in the field. And, I think we as neuro-ophthalmologists, if you talk to any neuro-ophthalmologist, they talk with so much passion about what we do. You'd be surprised that more folks don't want to do it. We really love what we do, but I think we don't do the best job of telling our own stories. Because we're not the ones sowing these misconceptions about neuro-ophthalmology. It's coming from outside our ranks, to a degree. And I think as neuro-ophthalmologists, we need to be a bit more vocal about how great our specialty is and how much of a positive impact we can have on our patients, our colleagues, our communities by the very specialized care we're able to offer our patients. We should invite them to come spend time in our clinics, see what we really do, and then have them come to Nanos to experience what Dr. Fiona Costello, University of Calgary, she calls the Super Bowl of nerddom, right? Neuro-ophthalmology. And if you really like it and you can vibe with the culture and the clinical and scientific research that's there that makes neuro-ophthalmology what it is, then it's probably for you. You should really be serious about checking it out. So I think breaking misconceptions is important. And anything that you do and you're trained to do over and over again, you get better at. So I don't think the argument of it being cognitively difficult it holds water to me, at least, because anything you do, if you put enough effort into it, you can become good at. In terms of reimbursement, I'm not begging for bread. Most ophthalmologists are not begging for bread. Sure, we don't get paid as much as some other specialties, but if you do surgery, if you are efficient in your clinics and you know how to take care of the business of medicine, you can do just fine monetarily. About half of ophthalmology trained neuro-ophthalmologists do surgery, so that breaks the surgery myths right there, whether it be plastics or PD or comp. About a third of neuro-ophthalmologists are private practice, so I think that breaks the myth of it being purely academic. And, we're willing and able to mentor those who really want to find out about what we do, just need more exposure and more information. And to that end, I am a part of the NANOS pipeline committee. I was part of the YONO committee before the Young Neuro-Ophthalmologist Committee. And what we're trying to do is, like I said, dispel these myths about neuro-ophthalmology, present neuro-ophthalmology as a truly viable specialty for more people. We do it through webinars, through NANOS meeting content and resources. There is a medical student membership now, members in training membership. There's a listserv where they can ask questions and get information. That is really getting information out there, getting the news about what we do and spreading the gospel, so to speak, about neuro-ophthalmology, so that we can bring more people into our ranks, cast a wider net, talk about diversity, what that means to ophthalmology, neuro-ophthalmology in a little bit. But, getting the word out there, being passionate about it, being honest about it. I mean, not everything that glitters is gold. It's not perfect, but for some people, if this checks your boxes of what kind of doctor you want to be, what you want to do, and the kind of patients you want to see, it's definitely for you.
I love that spirit and passion behind it. It's actually similar to the vibe, as you know, that we have within peds, because I think neuro-opt and pediatric ophthalmology and adult strabismus are similar positions where we've sort of, both fellowships go unfilled in different roles, and we're seeking people to really get the exposure and share the passion about what an important and valuable career it is. You shared how in neuro-ophthalmology there's a balance between neuro-ophthalmologists that don't do surgery and the do surgery, and it sounds like you've really been able to bridge that gap well. You do orbital work, you do strabismus work, you do lid procedures. Share with us your perspective on your training in that, and how you've not only felt comfortable acquiring those either in training originally or over time, and then what's your message for others going into neuro-ophthalmology about how to do that? I mean, I know we have neuro-ophthalmologists here that do cataract work and comprehensive work, and others are able to carry some of those shields well, like you do. But what's your message as you share a passion for neuro-ophthalmology, being a surgeon and doing that well?
I love that question, and I'm really happy to answer it. I did my residency at Dean McGee, where I was exposed to surgical neuro-ophthalmology. And at that point, when I did my residency, I did all my training at OU, undergrad, medical school, now residency. And I had mentioned Dr. Ferris before, he didn't want me to be inbred, so to speak, going through all of my training. So in fact, he took a fellow before I could show interest in the fellowship, so he could basically kick me out of the nest, so to speak. And, I was a little salty at that point, I'm not going to lie, but it was probably the best thing that he could have done for me, because he really cared about my training. And took a fellowship at University of Utah Moran Eye Center, and there I got great training from a wide variety of specialists. Neurologist trained, neurology trained neuro-ophthalmologist, ophthalmology trained neuro-ophthalmologist, and also oculoplastics. And my mentor there was Dr. Bhupendra Patel, and he helped develop the medial eyelid crease approach to the orbit, which is what I wanted to learn to use to do optic nerve sheath fenestrations. And in talking to him, he said that, great, I can get you the surgery. I mean, his actual words were, surgery is monkey's business. I can get anybody to do surgery, but I want you to learn to be a surgeon. That means preoperative care, evaluation, expectation setting, doing the procedure, becoming technically proficient at doing the procedure, and then post-operative care, taking care of patients afterwards, knowing what normal looks like, abnormal looks like, because you guys are surgeons. You guys know if you do enough surgery, you're going to run into complications, and you want to have been there, done that, sort of seen it, so that when you do run into those issues, you can take care of patients the best way possible. So I spent about a third of my fellowship doing plastics procedures. I actually did cataracts for the first 6 months, and I realized I didn't want to be an intraocular surgeon. And then after I was done with my year of neuro-ophthalmology fellowship, and I actually had to prove to my neuro-ophthalmology mentors that I could do the neuro-ophthalmology side, that I was competent in that, and let me do as much plastics as I did. I did 3 extra months of plastics with one neuro-ophthalmology clinic a week to support myself. And that was through the generosity of Dr. Randy Olson and Dr. Kathleen Degree, who allowed me to stay on and do that. And with that training, I'm able to do what I'm doing right now. And I think, talking about that, you didn't hear me talk about doing strabismus. I didn't do strabismus during my fellowship, but at Dean McGee, I did a lot of strabismus. I think I did 70 procedures as primary. And when I came out of fellowshipping, went to training, I was staffing residents at the county hospital, LBJ, Lyndon Baines Johnson County Hospital. And our strabismus surgeon there wanted to sort of go away from doing adult strabismus. And he knew I trained at Dean McGee, knew I did a lot of strab there. And he said, "You feel comfortable doing strabismus and staffing the residents?" And I said, "I think if I can get back on the bike, I think I could do it." So I spent a few days, OR days, doing cases with him, got my muscle memory back pretty quickly, and sort of hit the ground running since then. And staffing residents, doing simple to more complex surgery. Same thing with orbital and eyelid surgery. I got a really good, strong foundation in the principles and techniques of surgical management of patients. And I think you guys know this, and most surgeons know this. A lot of procedures that you end up doing in your career as you progress are not what you were doing when you first trained. Phaco came out, 80s, 90s. They were doing intracaps before that, but they got to learn how to do phaco emulsification and figure out how to do that. But it's the basics that you learn that give you the platform and the background to be able to learn and add to your armamentarium. So if you're solid in the fundamentals, you can learn and become proficient at other procedures, newer procedures. And obviously you want to make sure you have somebody who can come in and sort of audit you and make sure you're not doing anything that's inappropriate. And I think that was the case for me. I was able to do that, add these procedures to my armamentarium. And I feel that I can really take care of most of my neuro-ophthalmic patients from a surgical standpoint without referring them. So I don't get referred plastics to speak. It comes organically out of my neuro-ophthalmology practice. So a thyroid patient, I can take them from orbit, decompression, all the way to lid surgery through the strab. Paralytic strabismus, I can take care of that. Paralytic eyelid malpositions, I can take care of that. I take trauma call 1 week a month. So, I did a trap fracture on last Tuesday morning. We had to take care of that patient quickly. So I feel comfortable doing these things. I know the things that I'm not capable of doing, I'm not comfortable doing. I don't do lacrimal drainage surgery, wasn't for me. I don't do eyelid periocular cancers, wasn't for me. I do simple orbital biopsies, tumor removal, but I don't do anything more complex than that. And it's gone well for my patients. I think the thing that I do as an orbital surgeon that I think it gets the most satisfaction for me is optic nerve administrations, because that's the neuro-ophthalmic procedure that I can offer my patients that I think impacts them significantly. And it's been really a pleasure and a joy to be able to do that. Sorry, go ahead.
Oh, I really appreciate that perspective of you sought training in the areas that you had passion and wanted to build on. You had relationships that were able to foster that, and you saw your career in encouraging others to continue to see horizons to expand. One of the conversations between strabismus and neuro-opt is, when some people in the strabismus circles would say, a strabismus training goes over a year and we'll have 400, 500 cases. And others, in certain other programs will have less than that. And what level get you to certain comforts? But as you're saying, it's a trajectory. And I think the most important piece of all of this is to use relationships and your own humility and curiosity in a way to expand a practice for the benefit of patients. I really appreciate the sense of working together, because I think every practice, whether you're doing multiple things out in one or sharing, is when you come in learning from each other and even operating with each other. Just having, not just in a 3-month period, but over time, that continuing to learn from and be reflective on your surgical skill. So whatever your training is, you are, all boats are rising together in the care of the patients. But I just applaud that perspective, both in humility and in curiosity in exploring these aspects of your career.
Yeah, definitely. I think if you don't stay humble about being a surgeon, surgery will humble you.
Yeah.
You got to really be on your P's and Q's and mind what your limitations are, and don't stretch yourself past what you can do. And my background in surgical neuro-ophthalmology is a little bit different. I sort of made my own fellowship. The more traditional route is to do a fellowship in neuro-ophthalmology and a fellowship in plastics. And that route is still available, but I think there are more programs out there that are offering surgical training, whether it be strab or lids or orbits with neuro-ophthalmology, to make it more attractive to trainees. And that's been, I think, a focus of our neuro-ophthalmology fellowship directors to make that information more available and that training more accessible to more people who want to be these kinds of neuro-ophthalmologists.
Yeah.
I think it's extremely unique what you've created and what you've done. And you talk about expanding your armamentarium, but I think that's actually the opposite. As you know, so many people, as they advance further in their career, they kind of scale back and they kind of come back to things they're more comfortable with. And you've done the opposite. You've just reached out and broadened so that you can really offer your patients front to back, you know, the concept of being able to offer your thyroid patient decompression and strabismus and lid surgery all in one shop, one surgeon, is really tremendous and very rare. So I applaud you. I think it's terrific and great to show the versatility of neuro-ophthalmology. It really does cross so many different spectrum. And, you know, when I did my fellowship, one of my fellowship preceptors did quite a bit of strab and I had zero interest. I was like, I don't even want to look at it. I'm not going to do absolutely not. Really, I just applaud you for taking on the hard stuff. So that's awesome. I have to ask selfishly too, I love a medial lid crease optic nerve sheath fenestration. It's one of my favorite procedures. It's just like the best. And I just we were presenting on this at ASOPers, doing bilateral same day. Do you do bilateral same day ever?
Yeah, almost all the time.
Perfect. Okay, we're gonna pool our data because nobody's published on this. I've got a couple people, so I'll contact you. We'll pool our data. That's great because we're doing them same here, bilateral same days. That's just terrific. It's so wonderful. You're such an advocate in neuro-ophthalmology, and then your other big passion and big space is mentoring minority students, African American students, bringing them into ophthalmology, increasing diversity in ophthalmology, which is so tremendous. And I'm such a believer that exactly what you said, you don't know what you don't see. And we have this huge deficiency in ophthalmology of diversity in our workforce. And I think a lot of it's from that early exposure. Our diverse candidates who are the best and the brightest aren't being exposed to ophthalmology, and we need mentorship on that earliest level. We need mentorship to our African American students in medical school to say, hey, you can be an ophthalmologist. Like, come with me, let me show you. And that's exactly what you're doing. It's so amazing. So talk to us about some of your initiatives in DEI, your passion for that, what's on the horizon for ophthalmology, all that stuff.
Yeah, it's a lot to unpack. I'll do my best. So I love what you said about representation and being what you can see. And, you know, there are so few of us URIMs, underrepresented minorities in ophthalmology, that we can't carry that burden ourselves. We can't carry that weight ourselves. And having individuals like yourselves who are willing to talk about DEI, number one, we'll get into that a little bit, and show folks the way. That's really important. Personally, I'm a mentor with the MOM program, the Minority Ophthalmology Mentoring Program. I've been so for the past 4 years or so. I also work with the Rab Venable Excellence in Research Program, with the Pathway Success Program, Maurice Knight, Darlene Pagliani Claudio, with the National Medical Association Ophthalmology Section. So I go to the annual meetings, I run the neuro-ophthalmology section, I talk to the trainees, try to inspire them to be neuro-ophthalmologists. I also serve on the board of the NMA ophthalmology section as alternate counselor to the AAO. I'll take over as the counselor in January. I'm also the vice chair of the NANOS DEI committee and become chair of the committee on July 1st. I'll serve on the pipeline committees and served on the UNO committee. So I have a lot of hats of things that I'm doing. I'm passionate about DEI because it was DEI applied to me that made it possible for me to do what I'm doing. And I have 3 young children and I want them to be able to have careers and whatever they want to do. And if they see me doing it, then they can see themselves doing it. Like I told you, I wanted to be a doctor since I was 5. And there was never any doubt in my mind that I could be a physician. I saw my parents doing it. I was literally them. Like if they could do it, of course I can do it. There's no question. So that's what makes me sort of take and want to do it. You asked about the future of DEI. What does it look like for students? What's on the horizon? It's a really good question. And I say that because with the current social and political climate, we're seeing significant, what I'd call backlash against DEI, right? And that includes the SCOTUS decision on affirmative action, initiatives, laws being passed in different states, even in medicine, laws being proposed to defund DEI.
Right.
And
I think people are retreating. For a while we saw such expansion, and then just in the past couple months, it seems like it's just a huge pullback.
yeah, retreating I think would be nice if it was just retreating. I think it's actually full force pushback. And a lot of these initiatives claim that DEI is dangerous ideology, and also reverse discrimination, reverse racism, and some say it harms medicine by lowering the quality of medical education and producing what they call physicians ill-equipped to meet the needs of their patients. I personally disagree emphatically with these statements because to me, and I don't throw this word out lightly, it's racist. I mean, how can you tell me that I don't add to the body of medicine, the field of medicine? I don't make patients' lives better. Somehow I water down the talent pool. And it's antithetical to what DEI does in medicine, which is what creates a workforce that is better representative of and equipped to take care of our diverse populations. We know there's evidence that patient-physician concordance, race, and cultural background leads to better outcomes. That's a fact. There's data out there that supports that. And I talk about this pushback in response to your question because it makes recruiting URIMs to medicine and ophthalmology a bit more difficult. It makes URIMs, those that support them, a bit worried and concerned about the future holds for them and their communities. Happy to say, though, that ophthalmology is a specialty, and its leadership, the AAO, AUPO, NMA, they stand firmly behind DEIA, which is diversity, equity, inclusion, and access. And they put out statements affirming the support for programs like the MOM program and against legislation that seeks to defund and roll back the gains made through DEI initiatives. So, we recruit a diverse group of trainees into ophthalmology and into medicine by having our eyes wide open. We understand not only the backlash against DEI, but the history of race, disenfranchisement of minorities, and how that got us to where we are today. We acknowledge that, and also how it colors our own individual views of what's right, what's good, who's capable, qualified, deserving of opportunities in medicine. Andropound gorilla in the room is a big stigma in our society and culture about what people are capable of doing as URMs, people of color, and what's desirable in residency applicants, right? I think a big way to counter that is to check your biases, check them at the door, and perform a holistic review. This is seeing each individual candidate for who they are, how the capabilities and lived experiences, in addition to their academic and professional accomplishments, can benefit our specialty. And most importantly, this is our true north: take the best care of patients in our communities via culturally sensitive and technically excellent care and research. And as a shout out to the AAO, the May edition of INET features the work being done by the Academy and its members to promote DEIA. It includes how to address the challenges to DEI that I mentioned earlier, and it's really inspiring. I'm proud to call myself an ophthalmologist, be part of this wonderful organization of people that are doing the good, hard work of making medicine better for all.
Yeah, I think there's been huge advancement in ophthalmology. So much of your work, the MOM program, it's amazing. You're absolutely right. I mean, it's indisputable data that shows that having a diverse pool of physicians is better for patients, and having a diverse workforce is better for your team. It's better for residency. It's better for the department. It's better for everybody. So, I mean, we all know that's not even something you can argue. Can I ask? We're going to go a little longer on this podcast, but I have to take advantage of you being here. You're such an expert, ORIFA. Coming from as a resident program director, we're flooded with applications every year for residency spots. We do a complete holistic review on every single app here at Mayo. We don't have any score cutoffs. We read them all front to back. I've heard you speak out against things like step scores and other ways that we can collectively or quote unquote objectively, even though it's not objectively, grade these applications. How do we look at applications in order to select people who are going to take great care of patients, like you said? Because it's hard, and there are objective metrics, grades, test scores, like those things do matter. Ophthalmology is hard. So what do you do to pick somebody who's going to take the best care of patients?
Great question. There's no silver bullet. I want to first start by saying that. But I think you've already mentioned a bit about what to do, right? you guys are being intentional, you're being purposeful, you're doing holistic review, you're looking at the whole body of work of an individual. We know that test scores do not predict what kind of doctor you'll be. They predict to some degree how well you pass boards, but that's pretty much it. Looking at distance traveled, looking at hurdles overcome,
Yeah.
looking at perseverance and despite obstacles. And we know that people tend to practice in places where they're from or for folks that look like them. So if you have a healthcare need and a burden in places where people are being disenfranchised and not getting the care that they need, you necessarily should be trying to select people who will take care of those individuals. Again, casting a wider net, being more inclusive, more holistic in your review of applicants. Things that I look at, and I'm on our residency application review committee and interview committee. You know, research is great. Writing publication is important. I don't like cat herding residents and medical students to do projects as much as anybody else. But I think looking at real world experience, like if you worked at a Denny's, if you worked at a diner, if you were a cashier at a store, like you had a job, you paid bills, you took care of something, you showed that you get up every day and go to work. And that speaks to me of responsibility, accountability, and those are the things that we need in residents. We need in physicians at the end of the day. So looking at things like that show a longitudinal, sustained effort in trying to be excellent and making yourself better, I think is important. But again, there's no silver bullet. We need to look more at the data as to what variables and characteristics do tend to translate into those doctors that are more capable of taking care of patients and not just passing tests and looking good on paper.
Yeah, fantastic.
I've learned greatly since partnering with Dr. Tooley here on podcasting, but you have two podcasts, and one is able to speak into diverse equity and inclusion and access issues. Share with us what that platform's been like for you, and I guess also your podcast on neuro-ophthalmology, but what's been your journey that way, awareness and the appreciation of the power of social media for those topics?
Yeah. So I have two podcasts, like you said. The first is called Sight for Sore Eyes, in which we address issues of diversity in ophthalmology with a minority perspective. The other one's called Out of the Blind Spot, where we talk about all things neuro-ophthalmology. And these podcasts were really born out of my identity as a Black academic neuro-ophthalmologist, of which there are about less than 20 in the country. And with the issues around race and representation in medicine and ophthalmology, as well as a workforce shortage in ophthalmology, this is where they came from. And they were born as projects that I did as part of my participation in the Academy's Leadership Development Program in 2023. Although my desire to do them predates this, and hopefully will continue as long as I can. For Sight for Sore Eyes, I want to tell the stories of minorities in ophthalmology, the issues that we face, the things that are being done to try to improve diversity in our specialty. And in fact, part of the motivation to do this podcast came from stories that were told by physicians on the Black Eye Doctors WhatsApp group, which I'm a part of. And it happened, I think, around 2022 after the match. They were telling stories about their experiences when they were told that they couldn't be doctors or they shouldn't be doctors, or, why are you trying to be an ophthalmologist, right? That's not for you, right? And then they're kind of telling these, look at me now stories. You told me I couldn't do it, but look at me now. Like, I did it, I'm successful, and I'm paying it forward. So I wanted to tell those stories and being able to have this platform and have the individuals come on and talk about their experiences and what they're doing. It's really inspiring to me. It's what keeps my fire going. And I think helping to have other URMs out there see people who look like them, tell stories that may be similar to what they're going through and persevere. I mean, you can imagine what kind of boost that could be to them and their path. Out of the Blind Spot is my attempt to spread the gospel of neuro-ophthalmology to as many people as possible so they'll know more about it, hopefully appreciate our wonderful specialty. It's also a recruitment tool, hopefully, because you can't, again, be what you don't know about. So knowledge is power. Podcasting has been an interesting journey for me. It's a somewhat steep learning curve. Big thanks to Jay Sridhar. Shout out to him for helping me early on to know what kind of things I needed to buy and how I needed to sort of go about the process. I write, I edit, I mix and produce all of my podcasts in my office at home. It's a big undertaking. It's a bit of a labor of love, but it's been fun and it's been good. I think the biggest thing that it's actually helped me with is speaking better. Because starting off, I used to talk really fast, want to kind of get through all my words, but helped me to slow down my speech, really fully enunciate my words, and be a better speaker, so to speak. And I hope over time, folks see the quality of the podcast have gotten better. I've tried to make them better, try to make them more professional. It's been a lot of work, but when you see an idea grow from a thought to an interview and then to a full-fledged podcast, it's really satisfying and rewarding. And if I've been able to impact anybody positively, even if I don't have a huge, wide listenership, and I don't, it's maybe my personality, I don't broadcast the podcast widely. I don't post them on social media. It's sort of by word of mouth, and who knows what's going on with me. So I'm not doing it for recognition or notoriety. I'm just trying to really get the word out there. But I really appreciate you having me on to talk about it. It's been a labor of love, but it's been one of the most fulfilling things I think that I've been able to do in my life. And my kids I think it's really cool to hear Dad on the radio speaking in his podcast voice. Something I think that I've gotten to cherish over the time.
Oh, well, huge shout out to both of your podcasts. I've really enjoyed listening to both of them. Some of the Sight for Sore Eyes with the history of Black people in medicine is so good, so informative. So anybody listening, check that out. Out of the Blind Spot, fantastic educational podcast for NeuroOp. Really, they're terrific. So we're happy to be in this space with you. You're amazing. And thank you so much for coming to talk with us. This was fantastic.
Yeah, you commented on the joy of seeing an idea and then some homework and then the podcast come together, being a blessing. And I do, I just the idea that you had and having you join us, I just appreciate that coming to fruition. You've been a blessing for our listeners and encouragement for anyone on these topics: neuro-ophthalmology, diverse surgical practices, DEI, and complementing what we're trying to do in access for care. Thank you for being part of this message for us today.
Yeah, thank you so much.
This has been a blast. Again, I love the work that you do. You're fantastic at it. Your platform is wonderful, and I encourage you to keep on doing it. It's wonderful.
You too. Thanks, Dr. Adeshina.
Thank you.
You can find all episodes of the Mayo Clinic Ophthalmology Podcast on our website.
Thank you for listening, and we definitely look forward to sharing more